Thank you, Dr. Vinita, for including me in this IC yet again. It's been running for many years now, and it's really a good course. Sorry, I'm jumping the queue. This should actually come in the end. So, if all the things that you do with them fail and you end up with a refractive surprise, what should you do? So, obviously, it's better to prevent than try to fix this. And we should identify which are the high risk patients. I'm sure a lot of this will be covered by the subsequent speakers, so I won't delve into that. You need to understand why it has happened. So, it's important to do some basic tests, go back and check your IL calculation, see if there have been some entry errors or if you use the wrong mode or something else has gone wrong. Usually, whether the lens is in place, whether it's tilted, is there phimosis which has moved the effective lens position, whether there's a capsular distension syndrome, is there viscoelastic behind the lens, etc., etc., and some difficult cases where you do expect surprises like scars, post-refractive, ectatic corneas, etc. Now, once you are in this situation where you have a refractive surprise, what are you going to do? You can fix this refractive error by one of these ways. You could change the lens if it's not too late. You could add another lens on top of your existing lens, which is the piggyback lens. You could do some sort of a cornea-based correction, which could be either surface or a LASIK or even smile. And then you might want to treat the cause if there's specifically like a capsular distension syndrome or the lens is not in place. You will try to fix that. So if it's in the immediate post-operative period, recheck everything, including the IOL calculation in pseudophakic mode. Check the preoperative data, IOL calculations. Make sure the right patient received the right lens and you didn't make some sort of an error of giving the wrong lens. And of course, capsular block syndrome is a very common thing, and you'll get a myopic shift. So you must look for that and keep that as a high in your index of suspicion. If it's a multifocal lens, patient has come 2 to 4 weeks after surgery, it may be good to just exchange the lens. But piggyback is also not a bad option. If the patient has come very late, then better to go for a piggyback or a surface a treatment on the cornea. If it's a monofocal lens, up to 4 weeks, we could do any of these options. But after 4 weeks, again, you don't want to really change the lens. Piggyback, a surface ablation or a LASIK. If you're doing a LASIK, make sure if you're doing a femto flap, the hinge is at the wound site. Otherwise, you'll end up with a problem in the flap. If it's a toric IOL, if the IOL is rotated, then you need to go and put it back in the original axis. If you have the original calculation, just look at that and fix it. If you don't have it, you can use this thing called astigmatismfix.com, or you could use an aberrometry like iTrace to help you plan the rotation. Examer laser treatment or an IOL exchange or a piggyback IOL could also be done in extreme cases. So this is this website astigmatismfix.com. You just have to enter the data and basically click calculate, and it will tell you in a diagrammatic fashion how much you need to rotate the lens in which direction, clockwise, anti-clockwise, and it will tell you the estimated residual astigmatism. So that's what you want to do. Okay, so IOL exchange is another option. This is a video I borrowed from Dr. Harshul Tak, my friend. So I think it's a good idea to put in the second lens first and then cut and remove the other lens, so it makes the IOL removal a little safer and you don't end up damaging the bag. That's what he's demonstrating here. And of course, then you put the lens at the appropriate axis. So I'll just show 2 cases and I'll close. One is this one case. Uneventful cataract surgery, everything was perfect. You can see it's a good rhexis, well-centered lens. But immediately post-op, refractive surprise was -2. So what could be the cause? It's right there. You can see there's a gap between the posterior surface of the lens and the PC. So this is a capsular distension syndrome. You can see there's trapped viscoelastic, which has caused a myopic shift. So one of the ways to manage, which has been described, is that you yag the peripheral anterior capsule, or you could go and wash the bag. So that's what we did in this case. You can see that little star-shaped yag there. So you have to choose an area where the haptic is not there, peripheral to the optic, and you can yag it, and hopefully that will release in a viscoelastic. This doesn't always work. So in this particular case, it did work. You can see then in retroillumination and in high mag, the side of the opening. So here it resolved, and the patient got back to emmetropic result. Otherwise, one could go and wash the IOL, or one could even do a posterior capsulotomy, but it's not ideal in the initial postoperative period. Of course, prevention is better than cure. Do a good wash. This was another patient, 61-year-old, underwent multifocal lens 6 months ago. Refractive surprise was like this, quite bad. Very unhappy patient. cylinder as well as spherical error. It was like a mixed astigmatism. And so she was planned for a piggyback toric sulcofix lens. There was obviously there was an element of phimosis also, which might have shifted the effective lens position. But I didn't want to do two interventions, so I just directly decided to do a piggyback and just enlarge the capsule opening. So we use this lens from the care group called Sulcofix, add-on Sulcofix, and I decided to go with a toric lens. So as you can see, we've enlarged the anterior capsule opening and then basically implanted Sulcofix lens in the sulcus like so. It has 4 haptics, so it sits quite nicely in the sulcus. There's another lens from Rayner called the Sulcoflex, which also works very well. You could use either of them. This works quite good. So this is the patient after surgery. You can see the 2 lenses there on the slit picture, and the patient did quite well. So who are the ideal candidates for a piggyback lens? Primary IOL is an intact capsular bag, normal or deep anterior chamber, not a shallow chamber, no glaucoma, no pigment dispersion, no endothelial problems. Choice of surgery for hyperopic errors particularly, and choice of surgery for patients who present late and have a significant higher order aberration which may not be laser correctable. So this is how you use the formula for piggyback calculation. I'm sure somebody will cover this in the subsequent talks. So the other lens, like I said, is Sulcoflex from Rayner, and that also works very well. I'll skip the video for that. So to conclude, refractive surprises are best prevented by good biometry practices and surgical safety practices. But if they do occur, they can easily be treated either on the cornea or a lens-based approach with good outcomes. Thank you.